today we will discuss about the drugs used for the allergic and inflammatory disorders of respiratory tract with a special reference to the asthma. So the drugs which are especially used for the allergic disorders of the upper respiratory tract, and also especially the drug which are used in asthma. Even though the animals, the asthma is a very rare phenomenon, even then we will see some of the drugs which can be used in case of the animal asthma. So the respiratory diseases with a possible allergic etiology are poorly defined on the ground of the conditions, especially in the animals, which includes the feline asthma. Yes, of course it is rare, less, but the pulmonary filtrations with eosinophilia, that's also known as PIE in dogs, and chronic obstructive pulmonary disease COPD, it's a especially in case of horses. All these are the pulmonary disorders of the respiratory system, which is common in case of the felines, the canines, whereas in case of large animals these are not so common. So all are believed to involve in the allergic reaction, whether inhaled allergens, example the mold spores from the hay, and bleeding in case of bedding in case of horses, and the house dust mite especially in case of the cats, or the migratory pulmonary parasites. So the inflammatory lung diseases have been recorded in case of the swine and other species following the inhalation of some of the irritant gases, especially the ammonia, because this happens whenever in a cattle shed, if the walls are very high, then there is no proper inflow of the air, then the ammonia toxicity may occur. So the symptoms of the allergic pulmonary diseases can vary from the mild recorded in the swine for the mild. So this is unstable highly. Then other species following the respiratory tract. So this is the pathophysiology of the asthma, where in which the allergens are coming and binding with that of the especially the lung epithelial cells, or they are also known as airway epithelial cells of the lungs. So they have got the cilia for the movement of the sputum, and also the varieties of the cells which cause the inflammation. So here whenever there is a allergens come and bind with or get inside the alveolar cells, there is a damage of the epithelial cells. So what happens is, during this epithelial cells damage, lot of the intracellular events activate, that is the activation of degranulation of this mast cell. So this is a mast cell, then lot of enormous release of the of course the histamines, then leukotrienes, then also the prostaglandins. So they will be deposited in varieties part of the lung, and the smooth muscles hypercontractibility will be there, whereas the involved interleukins are interleukin 6 and interleukin 8, and also the mast cells, and here also the basophils, then the eosinophils, then some of the chemotactic factors are also moved by the interleukin 6 and that's the leukin 8. And ultimately what happens, the smooth muscle hyperplasia will take place, then hypertrophy on chronic disorders, and airway remodeling or restructuring of the airway takes place. That's why the asthma, the drugs are very much required to get rid of all these particular things are concerned. Then the pathophysiology of the allergic and inflammatory disorders is like that. It's a pathological state of the lungs characterized by marked bronchospasm or bronchoconstriction. constriction. Then there will be inflammation, airflow obstruction, and bronchial hypermotility is concerned, and accompanied by the increased secretion of the mucosal edema, and there will be plugging up of the mucosa. The most common allergens impacted in feline asthma syndrome have not been accurately defined, especially the cats and also in case of some wild cats. So these may include human and the equine dander, especially the epithelium, and many times they are also allergic to the house dust mites. In humans, in addition to the allergens, a variety of the trigger factors like the infection, then some of the irritants, especially the pollution, then exercise, exposure to cold, suddenly it is cold, then many times it is psychogenic also. So this may be involved, and asthma is now recognized to be the primary inflammatory condition, and various modulators released during the inflammation are just like the interleukin, the histamine, and the eosinophils, basophils, and many inflammatory substances. So they are going to contribute to the complications of the respiratory tract. Then because of the inflammation, the airway is occluded or obstructed. Then the air passage becomes very difficult in this situation is concerned. Hence the windpipe become narrow and makes the choking, especially the difficulty in breathing. So these are the phase of the asthma development and drugs involved which are involved in the inhibition. So there are two phases, one is the immediate phase and another one is the late phase. So immediate phase is a allergen or non-specific stimulus will be there as varieties of the causes, maybe pollen grains, allergens, some of the gases which are irritant gases and other things. So these are going to activate the mast cells in the lungs, and varieties of the mononuclear cells like the basophils, eosinophils, monocytes, and many more white blood cells. Then the mast cells are going to release the spasmogens, or they are also the cis leukotrienes or the prostaglandin and histamines. So these three agents are going to be released, and these cause the bronchospasms as the receptors of all these are present on the bronchial, and this can be reversed by the beta 2 adrenergic receptor agonists. We have learnt it yesterday in detail, and the leukotriene receptor antagonists and the theophylline. So this theophylline is directly going to dilate the bronchi. Yesterday we have learned. Whereas the late phase, so infiltration of the cytokine releasing, that's Th2 cells and the monocytes, and activation of the inflammatory cells. Then because of this chemotoxins, so all these are attracted. Whereas the mediators like the LT4s and the neuropeptides, then the adenosine. So adenosine triphosphate is going to be increased. Whereas the eosinophil, basophil, etc., they are also cause the epithelial cell damage, and ultimately the airway inflammation is there, then airway hyperactivity will be there, and the bronchospasms and wheezing type of the syndromes, and also there will be severe coughing, and all these are inhibited by glucocorticoids, because these are all mediated by the leukotrienes, because the lipoxygenase pathway is totally inhibited by the glucocorticoids. They are very well used. So in case of the asthma, many times the beta 2 adrenergic receptor agonists and also the glucocorticoids, they are used combinedly. So the glucocorticoids as well as the beta 2 adrenergic receptors or the leukotriene receptor antagonists like montelukast or zeferlukast, and the theophylline, which is a xanthine inhibitor. So all these are many times combined. Then asthma has two phases, so already it is explained with the diagrammatic representation. So the initial phase, it's called as the asthmatic attack. So abruptly in response to the allergen or non-specific stimuli, and is due mainly to the spasm of the bronchial smooth muscles. So when allergens come in contact with allergic specific IgE, which is the type 1 hypersensitivity reaction, and the mast cells are getting activated. It's a very well known phenomenon. Then what happens? The activated mast cell release a large number of the inflammatory mediators by the mechanism which include the release of the granular contents of the mast cell. So mast cell rupture, and here the histamine, protease and TNF or tumor necrosis factor are also released, and synthesis of various papain phospholipid derived factors like the prostaglandin, the leukotrienes, the PAF or platelet activating factor, and production of number of the cytokines. They are also known as the interleukins. So in one word, what we can say is the entire immunological system get activated whenever there is an allergen. So the vasodilatation, then increased permeability, enhanced adhesion to leukocytes, and release of the various cytokines results in influx and also the inflammatory cells. Example, it is the lymphocytes, eosinophils, and also the macrophages from the circulating tissue, and these will set the late phase as it is indicated here. So this is in the initial phase, and this is the later phase. All these the chemotactic factors are going to be stimulated. Then there will be wheezing and the bronchoconstriction. So once again, this is explained as the early phase of the response and late phase of the response. In case of the asthma or the allergens. So here what happens, the allergens or the pollen grains, or they are going to activate the mast cells, and all these inflammatory mediators are released like the prostaglandins, platelet activity factors, and also the IgE. Then the histamines as usual. So these cells are going to stimulate B cells, then Th2 cells, then all these are going to mediate varieties of the cascades of the events. So the major histocompatibility complex and other things are also included, especially the interleukins are released and act on the bone marrow, which are stimulated. So they are originated from the bone marrow and going to act on the later the epithelial cells. Whereas as usual it is the mast cell, the allergens which will bind with the mast cell, and they release enormous quantity of the inflammatory mediators. So these are going to act on especially the airway, and airway will be damaged and lot of mucus will be produced. So the T cells and other cells, the eosinophils, they also act to, especially in case of asthma, and also with the macrophages. All these are going to be released. Whereas the late phase, especially, it is going to occur. So this is the structure schematic diagram of the cross section of a bronchiole, showing the changes that occur with severe the chronic asthma, especially the asthma. So entire the bronchiolar tree is edematous and inflammatory in nature. So the blood vessels or the capillaries will be dilated, then the eosinophils, epithelium and other things are thickened with the basal membranes. So the mucosa and submucosa, here you can see that it is totally enlarged. Then inflammation of all the anti-inflammatory mediators are surrounding this particular thing, especially the mononuclear cells and eosinophils. So because of this thing, the hypertrophy of the smooth muscles occurs and they start contracting. Then the mononuclear cells are also totally, the number is going to increase. There will be edema. Then because of the edema and other thing, there is constriction of the bronchiole. So this takes place. In the late phase, varieties of the expert stimulus and involves the progressing inflammatory reaction during the initial phase, whereas the cytokine releasing T cells and eosinophils, especially in asthma inflammation, addition to the usual inflammatory cells will also be there. And the release of cytotoxic proteins, like they are also known as eosinophilic proteins, and toxic oxygen radicals or the hydrogen peroxide. So they will damage the respiratory epithelium and the bronchial tree. So these also inhibit the mucociliary function and stimulate different nerve endings in the mucosa and cause reflex cholinergic bronchoconstriction. So overall, the airway obstruction of the asthma reflects the totally bronchoconstriction and bronchial wall edema and accumulation of the mucus and cells. As disease progresses, airways become plugged and ultimately there will be a collapse whenever there is a choke. So this is already explained. So now you can see that the drugs used for allergic and inflammatory disorders of respiratory tract are also the asthma. So here the varieties of the classification is there, like 5 type of the classifications are there, starting from the anti-inflammatory drugs. So in the anti-inflammatory drugs, once again the corticosteroids like the dexamethasone, prednisolone and beclomethasone are used, whereas the NSAIDs like flunixin and ketoprofen, so they are very commonly used in case of the bronchial asthma. Whereas some of the bronchodilators, as we have already discussed, like the adrenergic agonists, the epinephrine and isoprenaline, and also the clenbuterol and terbutaline. These are the agents which are very commonly used for adrenergic receptor agonists, especially the beta 2 type of the agent, and the muscarinic receptor antagonists like the atropine, then glycopyrronium, then the ipratropium. All these 3 can be used, whereas the methylxanthines like the theophylline and aminophylline, these are very potent, so these can be used. And also the leukotriene antagonists like the montelukast sodium and cephirlukast sodium, so these drugs can be used. Whereas some of the mast cell stabilizers are there, so that if C cells are stabilized, then there will not be any further release of the inflammatory mediators. So the sodium chromoglycate and the noradrenaline, and also the antihistamines, like all the antihistamines like chlorpheniramine maleate, diphenhydramine, promethazine and cetirizine. So these are very commonly used antihistamines in case of the asthma is concerned. Whereas the miscellaneous drugs are the serotonin antagonists like the cyproheptadine and ketotifen. So these are the serotonin antagonists. Whereas the nasal decongestants include the epinephrine or adrenaline and pseudoephedrine and phenylephrine. So this is the classifications. So just anti-inflammatory agents like both steroids and non-steroids. Then all the adrenergic agonists, muscarinic receptor agonists, antagonists, methylxanthines, leukotriene antagonists, then the mast cell stabilizer like sodium chromoglycate, antihistamines, miscellaneous drugs. So overall, this variety of the drugs are used in the treatment of the asthma. So coming to the first one, that is the anti-inflammatory drugs. So in that we have already learned about the corticosteroids, in which the glucocorticoids remains the most effective long-term therapy for the feline bronchial asthma and are the drugs of choice for the treatment of the canine and feline allergic respiratory disease. So the corticosteroids are very beneficial, especially in cases of the severe crippling asthma, and those are not responsive to the standard bronchodilator therapy. So these agents should be kept as the last resort because these are very potent agents, and as they inhibit the inflammation totally, they should be kept at the last. However, these drugs have limited use in case of the recurrent onset of the asthma, that is status asthmaticus. So this is the mechanism of action. Already we know that how they are going to act, especially the glucocorticoids. So this is the mucous membrane, airway mucous membrane, and they are going to pass the airway mucous membrane, and what they are going to do is they are going to activate the heat shock protein, especially on the nucleus, then they have got a very specific the glucocorticoid receptor. So this is a membrane bound receptor, the nuclear receptor, especially the nuclear hormone receptor, and subfamily which includes the receptors for steroid hormone like the thyroid hormone, vitamin D and retinoic acid. All these are located on the DNA, of course. So the glucocorticoid response elements, they are there here. Then the change in the what happens is decrease or increased accumulation of mRNA within the target cell occurs. Then decreased or increased transcription of the genes coding the specific proteins, and also the changes in the rate of synthesis of the specific proteins that carry out the biological actions of the hormones. So they will be hampered. So totally the varieties of the cells which are involved in the inflammation are intracellularly blocked by the glucocorticoids. So these are all the effect of the corticosteroids. So they are going to suppress all these structures. The number of the eosinophils totally decreased, then T lymphocytes, then the cytokines totally suppressed. Of course, the number of mast cell that is expressed, so they are decreased. So the macrophage induced cytokines are also totally they are decreased in the quantity, whereas the epithelial cell especially they are going to act and decrease the cytokines and also the inflammatory mediator. The vascular endothelial cell, the leakage, especially the edema fluid leakage, it is stopped, and airway smooth muscles also it is going to act. So the expression of the beta 2 type of the receptor they are increased, whereas the cytokine receptors will be decreased, and they are going to decrease the mucus gland secretions which are from the mucus gland. So overall effect of the action of these agents is the immunosuppression. That's how they are going to act in a proper manner. So the explanation is like this: the corticosteroids acting by stimulation of the biosynthesis of lipocartin, a protein that inhibits the phospholipase A2. So here in this particular chart you can see that it is going to inhibit the phospholipase A2. Then by preventing the formation of the prostaglandins, leukotrienes, then the platelet activating factor, the corticosteroids decrease the leukocytes accumulation, especially inside the cell, and prevent the reverse vascular permeability and also the vasoconstriction, and reduce the release of additional mediators. So in addition, they induce eosinophilia and also the lymphopenia, means the lymphocytes are totally they are decreased. Then after macrophages function, modulate immune responses, then inhibit fibroblast growth and may stabilize mast cell and also the lysosomal membrane stabilizer. So lysosomes are also not broken down. Thus the corticosteroids can modify all phases of inflammation and important in the treatment of the asthma. So they help to restore responsiveness to the adrenergic agonists. Then once resistance to them develops and assist to improve the mucociliary clearance of the airway and the debris and other thing will be get out of the body. But they have got their own adverse effects, as it is already indicated that these are the immunosuppressive property and associated with long-term administration. So there is reduction in the resistance to the infectious agents and also adrenal cortex suppression will be there. So we can here see that the cortisols and the release of the cortisols and ACTH and CR. So totally after several weeks it is going to be a decreased after the high dose of exogenous administration of the glucocorticoids. So the adverse effects, especially in case of dogs, include the dull, dry hair, then hair cortex will be dry, there will be weight gain, then there will be vomiting, the diarrhea and elevated liver enzymes like AST, ALT, etc. and also the GI ulcerations and behavioral changes will be seen. That will be reflected here by the atrophy of the adrenal gland and the suppression of ACTH and also lack of ACTH stimulation, and the glucocorticoid therapy is what happens is discontinuation of glucocorticoid therapy will once again it will reappear, or that's why it is called as the glucocorticoids should be withdrawn in a gradual pattern, because or else it will cause the fatigue, nausea and vomiting and diarrhea, the mucous weakness, weight loss, then the hypoglycemia and many more disadvantages will be there. But hence the sudden withdrawal should not be done, and especially what happens if we suddenly withdraw the hydrocortisone replacement, then the fatigue, all this, especially the drowsiness, muscle fatigue, the weakness, etc. will be there. So the adverse effects associated with immunosuppressive doses are common and potentially they are very, very dangerous. Then the dosage regimen, especially in case of the emergencies, so if there is a status asthmaticus, then the emergency medication is given, especially the intravenous corticosteroids such as the dexamethasone, a long-acting corticosteroids, the prednisolone, a short-acting, or also the long-acting betamethasone may be used, and initially they are administered as IV to save the life, then followed by the maintenance by oral prednisolone. So twice daily therapy should be used for initial control of the signs. So the signs, especially particularly in patients who are serious then ill, then it will be followed by the alternate or every third day therapy at the lowest activated dose. So that should be it. The glucocorticoids can also be administered via the aerosol route and the rapid local effects. So although studies have not proven the efficacy of aerosolization in small animal, this route may be indicated for especially in case of the human beings. So when they are all intolerant to systemic maintenance of the glucocorticoid therapy, because uh, if we use the glucocorticoids, then they cause the immunosuppression and many more side effects. So uh, whenever this is not indicated, then the glucocorticoid topical therapy is indicated. So the NSAIDs, of course, are occasionally used for the treatment of the respiratory inflammatory diseases, but their exact role in such condition is not clear. The NSAIDs effectively block prostaglandins biosynthesis through the inhibition of the cyclooxygenase enzyme, but they do not appear to have any effect on the leukotrienes and other chemical mediators inflammation. That's why the phospholipase pathway is not affected with the NSAIDs. So they also lack the suppression of the immune response, yes, which we always accompanies the anti-inflammatory actions of the corticosteroids. So the ventilation of the gaseous exchange and pulmonary hemodynamics can be improved by the NSAID administration. So the flunixin meglumine, you have learnt in the non-steroidal anti-inflammatory agent NSAIDs. Flunixin is recommended for particular purpose, especially the asthma treatment. The drug of non-steroidal drug that is used is the flunixin meglumine, and another drug is the ketoprofen and the flunixin meglumine. So these two drugs are commonly used in the treatment of this acute bovine inflammatory emphysema and the edema, and may significantly reduce the mortality due to the condition like acute bovine pulmonary emphysema. So as we have discussed already, the bronchodilators are also of very important therapy for the control of chronic bronchitis in dogs and asthma syndrome in case of the cats. So whereas the short-acting beta-2 adrenoceptor agonists such as the clenbuterol are the first-line treatment for the acute asthma symptoms, whereas the non-selective beta adrenoceptor blockers such as the epinephrine and isoprenaline have efficacy similar to that of the selective beta-2 adrenergic receptor agonists, but usually they are less used because the concerns regarding excessive cardiac stimulation, because the beta-2 type of the receptors are present both in cardiac tissues and also in case of the another tissue, that is the bronchial tissue. So if a drug is given, whether it's a selective or non-selective, it will act on the both type of the receptors. So we cannot tell the drug that don't act on the heart and only act on the bronchi. So both it is going to cause. So the muscarinic receptor antagonists such as ipratropium bromide are often used in the adjunctive therapy with beta adrenoceptor agonists. So to provide the additional benefit in patients with moderate or severe respiratory disorders. So the leukotriene antagonists, just like the zafirlukast, are an alternative to the primary drug, but are not preferred, especially in case of asthma is there. Then the third agents are the mast cell stabilizers. So these are now emerging agents because the mast cells are the culprits for releasing the main inflammatory cells like the prostaglandins and also the leukotrienes and the histamines. So the chromoglicic acid, or it's also known as chromoline, chromoglycate or else the another spelling is there which contains the Y, chromoglycan. It's a synthetic hormone derivative which inhibits the degranulation of mast cells which is stimulated by the trigger stimuli. So this chromoglycanic acid is very commonly marketed as the sodium salt and is known by the name sodium chromoglycate or chromoline sodium. So this is the trade name. Thus here you can see that this is a preparation for the inhalation. The sodium chromoglycate is present as a nebulizer or the inhalation. So these are devoid of the bronchodilatory property, but the sodium chromoglycate inhibits the antigen-induced bronchospasms as well as the release of histamine and other mediators from the sensitized mast cell. Especially in case of allergic type of the reactions, this agent is very good, which is a mast cell wall stabilizers. So this is the mechanism of the mast cell stabilizer. So these are all the mast cells which are containing so many inflammatory mediators, and the IgE is the one which is the stimulus factor which binds with the specific receptors on the mast cells which get sensitized. So the relative antibodies, the antigens, they are going to attach and they are sensitized. So the mast cell stabilizers like maybe natural, semi-synthetic or synthetic, and there are various the novel agents are also there and the novel users are there. So the degradation of this degranulation of the mast cells will be inhibited by this sodium chromoglycate. So it is the antigens here are going to combine with that of the IgE type of the antibodies and are going to stabilize the cells. So in detail, the sodium chromoglycate inhibits the mast cell degranulation by stabilizing the mast cell membrane. So it is postulated that they block calcium channel, which is essential for the mast cell degranulation, and stabilizing the cell, thereby preventing the release of the histamine and related the inflammatory mediators. So one suspected pharmacodynamic mechanism is blocking the IgE mediated calcium channels. So these IgE mediated calcium channels, if they are inhibited, calcium will not get inside the cell, especially mast cell, and without intracellular calcium the histamine vehicles cannot fuse or the together, and the exocytosis may not happen. So the cell membrane and degranulations will not happen, and there is evidence that it depresses also exaggerated neuronal reflexes which are triggered by the stimulation of the irritant receptors especially, and they may also inhibit the release of the T cell cytokinins. So these are all the mechanisms, and apart from this one, the chemotactic factor of the inflammatory cells are also inhibited. So here you can see the mechanism of action. So a lot of the mechanism of action is there. Then the mast cells, then this chromoline, that's the prodromine, then it's going to act on the mast cell and inhibit the calcium dependent inflow of the calcium, especially the calcium channels. So these are going to inhibit the allergens and also the allergic or pollen grains from varieties of the substance. So the hypersecretion and pruritus and sneezing all will be stopped if we use the chromodine, etc. So here also you can see the varieties of the mast cell. Mast cells are involved in varieties of the reactions like the venom-induced damage and self-injurious behavior, then the irritable bowel syndrome, post-operative pain, the neuropathic pain, then sickle cell anemia, the cancer, then fibromyalgia that happens in case of the herpes virus infections, then bladder pain syndrome is so all these are mediated by the mast cells. So the ATP, these are all the other inflammatory mediators involved like chemokines, then the nerve growth factor, then all these estrogens, IgE, etc. activated mast cell releasing mediators. So these are all the mediators, and the mast cell stabilizers like the alpha adrenoreceptor agonists, and also what happens is initially the bronchiole will be like this, and after application the bronchial dilation occurs. Then the pharmacological effect of this drug is long-term treatment with sodium chromoglycate decreases cellular inflammatory reactions, and also the bronchial hyperactivity and bronchospasms may be induced by the allergens, especially then irritants, the cold airway, exercise, all these are going to be reduced. However, it does not interfere with the antigen antibody reaction, and also does not antagonize the bronchoconstrictor action of the histamine. That's the disadvantage of this drug, and also the different acting acetylcholine and the leukotrienes which act in the different manner. So therefore it is not effective in giving during the asthmatic attack or already existing bronchoconstriction. It is not going to release. Whereas the pharmacokinetic of this agent is, it is not absorbed or poorly absorbed from the gastrointestinal tract and is not administered by the aerosol route. And after administration, only a small fraction of the inhaled drug is absorbed systemically, which is readily excreted through when changed in the urine and also in case of the bile. And the drug has very short half-life, that is 1 to 1.5 hours, and thus effective therapy depends upon the frequency of aerosolization, and this limits its utility in the treatment of the animal disease, because in case of animals you cannot give the recurrent administration. So the clinical use of the chromoglycate is useful in case of the inflammatory reactions, especially in case of veterinary practice. It is used for the prophylaxis of COPD, especially in case of horses, which is administered by inhalation using a face mask prior to the expected exposure to the allergens. The length of the protection depends upon the number of consecutive days the drug is administered. So as the half-life is very short, so it needs the recurrent administration, and 4 days of the sodium chromoglycate administration may protect the horse up to 20 days. So that means once the mast cell is rupture of the mast cells, if it is inhibited, then it will stand for the 20 days. So it is commercially available in different formulation as the nasal spray, especially in case of rhinitis, nebulizer solution, inhalants for the asthma, the ophthalmic drops for the conjunctivitis also, and oral concentrate for the dermatographic urticaria and ulcerative colitis, then the food allergy wherever the mast cells are involved. And another drug is the nadochromyl sodium. It's available as the 2 mg per actuation prescribed inhalation suspension. So it's having whereas in case of human patients, it requires twice daily dosing. This is the nebulization. So this is a nebulizer of the nadocremil, which is commonly used in case of human medicine. So it needs investigations for the veterinary medicine further. Whereas the antihistamines are the H1 receptor antagonists. So these diminish or abolish the main actions of the histamine in body by the competitive blockade of the histamine. The role of the histamine in hypersensitivity reactions is already very well established. So the histamine is one of the many autokines involved in hypersensitivity reactions or asthma. So antihistamines have limited use in the treatment of the allergic respiratory diseases, especially in case of the animals. In animals, the chronic disease, the use of H1 receptor blockers may be harmful because of their inhibitory effect on the airway secretion. That's one of the disadvantage of the antihistamines, especially in case of chronic disorders. And several of these agents, however, do exert some central effects through cough center and may reduce the bronchospasm. And these reactions, antihistamines like the diphenhydramine, or else the popular trade name is Benadryl, and the promethazine hydrochloride, which is also known as the Phenergon, are very commonly used in case of the cough remedies of the animals. Then the miscellaneous agents are the serotonin receptor antagonists. So they are not so commonly used in case of the animal practice, especially the bronchial diseases. One of the agent that is used is the cyproheptadine. So it is an antihistamine with serotonin antagonist and also a calcium channel blocking properties. That's why. So if the calcium channels are blocked, then bronchoconstriction will be reduced. So it may be used for the prophylactic in case of the feline asthma. So however, its use is recommended only when other agents are not acting or they have failed, or else it is the cyproheptadine is not commonly used, just like the corticosteroids. And most likely the adverse effects seen in the cyproheptadine are related to CNS depressant activity or the anticholinergic activity like the dry mouth or xerostomia. Then ketotifen is also another agent which is the serotonin blocker, and some degree of the H1 receptors are also blocked by ketotifen. And also it has got the mast cell stabilization actions. So the phosphodiesterase inhibition, the restriction of calcium entry, and the leukotriene, that's the C4 and D4, that's the LTC4 and LTD4. So that's why their antagonism have been demonstrated with the ketotifen fumarate tablets. So the trade name, as it is indicates that astafen, it is the drug used in case of the asthma, and it is not a bronchodilator but produces some reduction in delayed onset of the airway obstruction, especially in case of the human diseases. Though this drug can be given orally and may require 3 to 4 weeks to produce the desirable effects, and the side effects are the drowsiness and sedation are usually the side effects. So in case of veterinary medicine, detailed information on the ketoprofen, especially the respiratory tract and the COPD, is not well established. And the nasal decongestants with alpha adrenoceptor agonist activity produce the vasoconstriction in smoother membranes, which reduces swelling and the edema. And these drugs are used topically as nasal decongestants in the allergic and viral rhinitis, and also systemically in case of the respiratory tract, the decongestants. So the intermittent topical therapy is preferred to facilitate the breathing and to reduce the volume of the nasal secretions or nasal discharges. So example of alpha 1 adrenoceptor agonists, whether they are the partial or full agonists, are ephedrine, then pseudoephedrine, then phenylephrine, then the phenyl propanolamine, then the nefazolone. All these are the alpha adrenoreceptor agonists. So here the nasal decongestants are used. Then like this, the supridine tablet, which contains the phenylephrines, contains the phenylephrines as 10 milligram per tablets. It can be useful. Then the mechanism of action of this decongestants can be also explained here. Just like the oxygen is entered here, then it is containing the blood vessels, then the nose passage of the air, whereas the blood vessels, there is dilatation of the blood vessels, then the inflammation occurs, then the airway passage gets narrowed, whereas the alpha receptors are present on the blood vessels, and the stimulation of this receptor is going to block the expansion capacity of the blood vessels and also clears the contraction of the blood vessels. Then there will be easy flow of the oxygen is noticed. That's how the airway decongestants, they are going to act. Then the decongestant activity of the ephedrine mixed along with the non-catecholamines is particularly dependent on the norepinephrine release from the adrenergic nerve terminals. So therefore the ephedrine use may deplete norepinephrine storage granules, and the chemical becomes refractory to its effect. So one need to be careful. So in addition, the rebound condition may result from the secondary beta adrenoceptor effects, as the receptor upregulation means the total number of the receptors will be increased. So overall, the use of the decongestant in veterinary medicine is not a common thing, and also it is not so diagnosed properly. And that's about the drug acting on the respiratory system. And study well. Have a nice day. Once again, we will meet on the Monday at 9:30 a.m.